A very good evening,
Wait, wait,
everybody.
wait,
And
wait, wait, wait. We are live.
a very good evening, everybody. I welcome you all to the YOSI Journal Club on 17th August, that is today evening. The much, publicized publish or perish was what began the idea for the YOSI Journal Club. And the whole cycle of how the idea evolves into a research and how it is written and published needs to be learned meticulously by all young ophthalmologists. And hence we started the YOSI Journal Club. You might be aware of the YOSI Governing Council, which has our past president, Dr. Digvijay, myself, Dr. Sonal. Dr. Divakant Mishra is the vice president. Dr. Karan Bhatia is the secretary. Dr. Avnish is the treasurer, and joint secretaries, Dr. Nilesh Kumar. And now I would also introduce you to our executive members. Dr. Nupur has already, a well-known figure who's already dealing with the journal club as well as the other cultural activities in YOSI. The other executive members are Dr. Aditya Sethi from Delhi, Dr. Ankita Aishwarya, Dr. Anuj Kodnani, Dr. Anujit Paul, Ashish Ahuja, Ashwini Kumar Behra, Dr. Bhavik Panchal, Dr. Divanshu Agarwal, Dr. Gunjan Buddhiraja, Dr. Gunjan Saluja, Dr. Hirika Gusalia, Dr. Isha Acharya, Dr. Karthikeyan Mahalingam, Dr. Kriti Gupta, Dr. Madan Gopal Viji, Dr. Prasanna Venkatesh Ramesh, Dr. Savnik Sen, Dr. Saurabh Deshmukh, and Dr. Zain Khatib. So basically, the entire spectrum of young ophthalmologists, ranging from your first year when you start dealing with the various research articles for your or we should call them seed articles for formulating your own thesis design, to the second year PGs who should understand how to present journal clubs, and then the third year who has to submit his thesis for a journal, and then the fellows who want to enhance their research, and then the young ophthalmologists who have begun their practice need to know how the research points should be incorporated into their clinical practice. And hence this journal club will help us understand how to read between the lines and understand how the researcher has made a study and how it can be useful to us. Now, the research literature that will be presented here will begin with the definition of the problem. The research question will be dealt in detail, the variables, the selection of the subjects, the research design, whether it was appropriate or how it could have affected the results, the particular design that has been taken by the researchers. Then the analysis of the data, interpretation of the results in the specific MARI format. And in every journal club, what we are doing is we are assigning a particular presenter who is generally a fellow or a PG. He will be assisted by a mentor who will be guiding how to make that presentation and to not leave out any important points. The topic will be moderated, and a research expert will give you the nuances of the statistical inputs of the particular paper. The panelists will be subject experts who will deal with the positive and the negative aspects of the study. And if any latest research is there on the topic apart from that particular paper, they will try to highlight all those points also. So the MARI is the method, assignment, assessment, results, interpretation, and extrapolation. These are the step-by-step approaches to dealing with medical evidence. You all are most welcome to send in more articles or suggest if you would like to present and be a part of this. So the first journal club began in 2021 in March, and then came the endophthalmitis. Then the third session was in cataract surgery, ocular oncology. We've had pediatric ophthalmology and oculoplasty also. Today, the journal club is on glaucoma, and I'll share with you all the expert panel and the presenter details now. The paper that we are dealing with is glaucoma progression after lens extraction in primary angle closure glaucoma according to the angle closure mechanism. This was published in the Journal of Glaucoma, which has an impact factor of 2.290. This Journal of Glaucoma is freely available to the members of World Glaucoma Association, and this paper was published in the April 2022 issue. So our statistical expert for today is Dr. Sabyasachi Sen Gupta, who is not just the associate editor of Indian Journal of Ophthalmology, very good Vitrutina expert, and also the founder of Sen Gupta's Research Academy. He's helped so many students learn about the nuances of research. Our expert panel includes Dr. Anu Joon, who's Assistant Professor at Maulana Azad Medical College, New Delhi, Dr. Prasanna Venkatesh Ramesh, who's in a private hospital in Trichy, Dr. Saiban Sethi, who's at Gurugram at Arunodaya Desert Eye Hospital. Our mentor for today is Associate Professor of Ophthalmology at KGMU Lucknow, Dr. Rajat Mohan Srivastava. The presenter, Dr. Anujit, has done his MS from Mahatma Gandhi Medical College and Research Institute at Pondicherry. He has several indexed PubMed publication and has received a gold medal for peer review publications at the IGO Platinum Award in 2021. Myself, I'm Assistant Professor at SMS Medical College, Jaipur, and I'm also currently Executive Member of JOS and President of YOSI. So let's begin our journal club presentation. So over to you, Anujit, for sharing your slides now.
Thank you very much, ma'am. At the very outset, I would like to thank YOSI for this incredible opportunity. I'll just share my screen in a minute. Are my slides visible?
Yes, your slides are visible. Please go ahead. You can make them full screen.
Once again, a very good evening to everyone, and thank you again for this wonderful opportunity. The title of the presentation as well as the journal has been already mentioned by Sonal ma'am, but I'll just repeat it once again. From the Journal of Glaucoma, the title reads, Glaucoma Progression After Lens Extraction in Primary Angle Closure Glaucoma According to the Angle Closure Mechanism. So before going into the subject matter in detail, let us just review the aspect of primary angle closure disease. Currently, primary angle closure disease spectrum, as we know it, has three subtypes, mainly primary angle closure suspect, where you have greater than or equal to 180 degrees of iridotrabecular contact without any evidence of elevated IOP or glaucomatous optic neuropathy. In the second class, you have primary angle closure, where you, along with the first class, you also have elevated IOP or presence of peripheral anterior synecdoche. And in the last class, where you have primary angle closure glaucoma, you have an iridotrabecular contact greater than 180 degree with elevated IOP and glaucomatous optic neuropathy. The primary treatment has conventionally been a laser peripheral iridotomy, which has been the main indication, however, in pupillary block subtype of primary angle closure. And the role of lens extraction has been also dealt with in detail, especially in the EAGLE study, which has shown clear lens extraction has its advantages over LPI in relieving pupillary block, in deepening the anterior chamber, in resolving the adhesion between the anterior chamber angle, and a reduction in IOP. This brings us into the rationale for this current study. The current study is a study which has been taken from the ASCEND glaucoma progression study, which actually concluded that there is structural as well as functional progression of primary angle closure diseases despite well-controlled IOP, which led the authors into the rabbit hole whether there is a mechanism of angle closure that is important in the progression of glaucoma. And since no previous study has classified primary angle closure disease progression according to the angle closure mechanisms, this study sought to investigate, compare the clinical characteristics and long-term progression of primary angle closure disease after lens extraction by the different angle closure mechanisms. This study was a retrospective observational cohort study that included all patients that were initially enrolled in the ASCEND glaucoma progression study. So the inclusion criteria were all patients that were diagnosed with PACD who had undergone lens extraction, particularly phacoemulsification with intraocular lens implantation between the years of March 2008 and June 2018. These patients were all reviewed for eligibility, and the institution review board waived the need for a patient consent because of the retrospective nature of the analysis. Any patient with history or current use of topical or systemic medication were excluded from the study. If there was any history of any intraocular surgery, including glaucoma filtering surgery with or without drainage devices, were excluded. Any patient with marked secondary angle closure mechanism causing glaucoma, like neovascular or uveitic glaucoma, were excluded. And patients who did not receive a follow-up examination for 2 years were also excluded. If both eyes were eligible, only one eye was selected at random, and all patients underwent follow-up examinations for 6 to 12 months, which include optic disc stereoscopic photography, RNFL photography, visual field testing, SDOCT, as well as ASOCT. As mentioned, all patients underwent a complete ophthalmic examination, Goldman application tonometry, gonioscopy, fundoscopy, optic disc photography, visual field, and optic nerve head spectral domain OCT. The guidelines for visual fields were a CETA 24-2, where only reliable visual field results were taken, and they required more than 5 reliable visual field tests after lens extraction. And once Anderson's criteria was met and visual field was repeated within 2 weeks of baseline measurements, the patient was included. And for OCT, the Cirrus guided glaucoma progression algorithm software was used, and structural progression, which was optic disc RNFL or OCT RNFL thickness progression, was confirmed. For anterior segment OCT, it was performed by an independent examiner in constant dim light and analyzed by a mass technician who was blinded. Cross-sectional scans were taken at 3 and 9 o'clock meridians at the nasal and temporal angles, and an image was selected if it had good central fixation, high resolution of the scleral spur, and no motion artifacts. And 2 specialists individually classified the angle closure mechanism. If no consensus was reached, a third glaucoma specialist made the final decision. This is a prototype image that was shared in the journal. The image on the upper left-hand side shows a case of pupillary block where there is a convex configuration of the iris, particularly an iris Bombay appearance, where the central and the peripheral AC remain shallow. In plateau iris configuration, the second type, the peripheral iris rises from the iris root in apposition or near the angle wall and then turns sharply away from the angle, as I'm showing with my mouse pointer, where the central anterior chamber is relatively deep. While in the third class, that is the exaggerated lens wall type, the intumescent lens pushes the angle forward, causing a small AC and a narrow angle, and therefore the iris appears to cover the entire anterior surface of the lens, giving it a volcano-like configuration. So with all these parameters defined, we went on to determine the parameters for glaucoma progression. This included progression of optic disc and RNFL defects, which were independently examined by 2 glaucoma experts. A comparison of the most recent photograph compared to the baseline, where the graders were unaware of each other's assessments, and each grader viewed the photographs with each eye before making an assessment. And in both graders determined the glaucomatous optic disc or RNFL progression, which was indicated by either increasing optic disc pallor, increasing extent of neuroretinal rim thinning, any excavation of the enhancement of excavation of the optic disc, or any widening or deepening or appearance of new RNFL defects. Once again, 2 graders classified each glaucomatous eye as either stable or progressing, and once there were conflicting results, a third reader made the final decision. Visual field progression was determined by event-based as well as trend-based approaches, which was defined as a significant deterioration from the baseline deviation at greater than or equal to 3 points at 3 consecutive examinations. And the definition was taken as a significantly negative slope with p less than 0.05, where the participants diagnosed with visual field progression when an eye showed progression during either one of these analyses. Data analysis was done by SPSS software version 22. Continuous variables were expressed as mean plus minus standard deviation. Categorical variables were expressed by linear association. Comparisons were made by unpaired t-tests, and univariable and multivariable logistic regression analysis or odds ratio were used to determine factors associated with glaucomatous progression. A factor with p less than 0.1 in the univariable model was taken as an independent variable for the multivariable model, and p less than 0.05 was considered statistically significant. Mean IOP reduction was defined as the mean difference between IOP before and after surgery, while postoperative IOP fluctuation was defined as the difference between the peak and the trough value of postoperative IOP in all measurements in each visit. So this is a bird's eye view of what actually happened in the study. Out of the 245 patients that underwent lens extraction in the initial ASCEND glaucoma study, 118 patients or 48.2% fulfilled the inclusion criteria to be included in this present study. In this present study, out of these 118 patients, they were classified into 52 patients recognized as pupillary block glaucoma, 51 patients as plateau iris configuration, and 15 patients as those with an exaggerated lens vault. The average follow-up period after lens extraction was roughly 6 plus minus 3.5 years. And it is relevant to note here that the average age was 65.4 plus minus 7.1 years, and all participants were Korean. There was no significant difference between the groups in terms of age, axial length, and central corneal thickness. Analyzing the results, visual field parameters, average RNFL thickness, baseline IOP, preoperative mean IOP, postoperative IOP fluctuation did not differ among the three groups. Of note was, mean IOP reduction after lens extraction was greater in the exaggerated lens wall group, and ACD depth was shallowest in the exaggerated lens wall group compared to the pupillary block and the plateau iris configuration group, respectively. Therefore, looking at the previous slide, which I had shown you, out of the 52 patients that were classified as pupillary block, 25 patients, that is 48.1%, showed glaucomatous progression. Out of the 51 patients categorized as plateau iris configuration, 15 eyes, or 29.4%, showed glaucomatous progression. And out of the 15 classified as exaggerated lens wall, 4 eyes, or 37.3%, showed glaucomatous progression. In the univariable analysis, lower CCT, lower baseline RNFL, lower visual field mean deviation, and angle closure mechanism showed a possible association with glaucomatous progression. While when these were taken in a multivariable analysis, lower CCT and lower baseline RNFL thickness were all risk factors for glaucomatous progression. In addition, in the plateau iris configuration group, the plateau iris configuration group was a protective factor against progression compared to the pupillary block group. So the study evaluated the clinical features and glaucomatous prognosis after lens extraction in patients with primary angle closure disease according to the angle closure mechanism. Progressed eyes had more severe glaucomatous damage with a low RNFL thickness and a low visual field mean deviation and visual field index. This was consistent with previous reports published. In this study, there was a mean IOP reduction of 12 to 30% after lens extraction, where the greatest reduction was observed in the exaggerated lens wall group. Other studies quoted by the authors have also had a similar reduction of 20 to 30%. In fact, the Eagle Eye study, which is a randomized control study, shows that clearance extraction is superior to laser peripheral iridotomy plus medication in PSC and PSCG. Lower CCT and lower baseline RNFL thickness were all risk factors for glaucomatous progression, and the PIC group had a lower risk for progression compared to the pupillary block group. The authors conclude that in eyes with PSCD may progress after lens extraction. Patients in the plateau iris configuration group are better protected against glaucomatous progression, and greater glaucoma severity was associated with glaucoma progression, which may be considered when PSCD eyes were followed after lens extraction. The author's interpretation of the limitations were the limited sample size, particularly in the last group. Another small subtype morphological type, which is the thick peripheral iris roll, could not be included. An average of 6 follow-up years were not enough to detect glaucomatous progression. All patients were Korean, therefore the results may not be generalized globally. And since this was a retrospective study, the criteria for lens extraction may not have been uniform among the subgroups. Breaking down the study according to the Mary criteria, the study question is well defined. However, the study sample size is inadequate. Out of the total sample size, only 48%, that is less than 50%, could be recruited into this current study. In considering the study population or the inclusion criteria, there is no mention of any systemic control of the patients included. Family history of glaucoma or any risk factors that may influence the glaucomatous progression has been completely excluded. Some, like high myopia or the refractive error or disc hemorrhages, has not been mentioned. In the exclusion criteria, if both eyes were eligible, only one was selected. However, the method for this selection or the method for this randomization was not mentioned clearly. The study period was well defined, but was still inadequate. Again, under the Mary criteria, like the authors have mentioned, the follow-up period was relatively less, with a standard deviation of plus minus 3.5 years, which was slightly erroneous. The average follow-up period for a progressor versus a non-progressor has not been mentioned clearly. And it is relevant to note here that the study was also supported by a grant from the Essen Institute of Life Sciences and Medical Center. For the measurement of outcome variables, OCT, ONH imaging, Humphrey visual fields were done independently and was appropriately done. However, one of the evaluators who evaluated these parameters was also the surgeon from the previous study. Therefore, this bias has been not rectified. Speaking of bias, since this is a retrospective study, the question of masking being appropriately done also stands in question. Even though they have mentioned glaucomatous progression, there is no comment on the cupping in case of progressors. In case of the exaggerated lens wall group, it is a relatively subjective assessment because there is no mention of any residual iridotrabecular contact or the post-op angle opening distance mentioned. The results were statistically appropriate. In my interpretation of the study, in fact, in the author's interpretation, they have concluded that PACD eyes may progress after lens extraction. And even though an IOP reduction has been mentioned, a reason for reduction of this IOP has not been mentioned. If it could be attributed to the visual field, initial visual field indices has also not been mentioned. The proportion of PACD patients, that is those with primary angle closure suspect, primary angle closure, and primary angle closure glaucoma in the respective angle closure mechanism cases, for example, pupillary block, plateau iris syndrome, and exaggerated lens vault have not been defined separately or evaluated separately for that matter. Indentation gonioscopy was done for all patients, but no results of the same have been mentioned in the analysis, whether there was any appositional or synechial closure or whether any patients had peripheral anterior synechia on examination has not been mentioned. It is relevant here to mention that the patients included under the exaggerated lens wall group had the highest fluctuation in preoperative IOP, however, had the best RNFL results compared to the other two groups. However, reason for this non-correlation has not been mentioned by the authors. So the results cannot be extrapolated for all populations, and other than the pupillary block or the plateau iris configuration types, the data is still insufficient for the results to be implemented for all morphological subtypes of angle closure mechanism. My interpretation of the study is that with a limited sample size, which is less than the original study, and with a lenient exclusion criteria that does not take into account the family history, the systemic features, or any risk factors of glaucoma, a limited 6-year follow-up, and all patients being Korean, the result therefore may not predict accurately for other populations or for long-term follow-up patients. Thank you very much for your attention.
Thank you so much, Dr. Anujit, for summarizing the results and the paper very meticulously. You've covered everything very nicely. And now I would request Dr. Sunny Sen Gupta sir, Sabyasachi Sen Gupta sir from Mumbai to please share the statistical nuances of the paper. He's a VR surgeon at Future Vision Eye Care. He's also the associate editor of Indian Journal of Ophthalmology. He's done his fellowship from Shankar Nethralaya, and he's also done a extensive research fellowship at Wilmer Eye Institute, John Hopkins, USA. His meticulously researched papers are all available in so many peer-reviewed journals, and he's also the founder of Sen Gupta Research Academy. Over to you, sir. Thank you so much for joining us.
Thanks, Sonal, and good presentation by Anujit. I'll just quickly share this annotated version of the PDF. And the first thing is that, the title says glaucoma progression after lens extraction in primary angle closure glaucoma. However, I don't think all these eyes were glaucoma eyes, right? There was some which, they didn't have raised IOP, perhaps. So it's not exactly clear, but I don't think all of them had glaucoma. So you could have really said primary angle closure disease according to angle closure mechanism. I think so this is relatively misleading because these are not all glaucomatous eyes. Again, I think Anujit has already told us that PACD, or it's essentially a whole spectrum from PSCS to PSC and then to PACG. So clubbing them all together is perhaps if there were majority patients who already had PACG, then it's but natural that they are all going to have some amount of progression, isn't it? So it would have probably have been better if they had just taken PSCS or perhaps PSC and excluded PSCG and then done this comparison, and that probably might have made more sense. When you look at the methods in the initial part, they say this is a retrospective observational study with 118 eyes that underwent lens extraction with a mean follow-up of 6 plus or minus 3.5. This mean follow-up is really not how retrospective studies are done. We would ideally say minimum follow-up of, say 3 years or 4 years or 5 years is necessary for us to include them in our analysis. And anybody with lesser than that follow-up have been excluded. This mean follow-up is always shown in prospective studies and not in retrospective studies. So, for this kind of study, even if it is a subset of a previous study, that mean follow-up is probably not the ideal thing to report here. The other thing is, you can actually look at the mean and standard deviation and see the 95% confidence interval. One way is to see that this standard deviation is more than half the mean. The 3.5 is more than 3. So it's a lot of variation there. And the way to look at 95% confidence interval, that is within what range does 95% of the population lie. The formula is actually given here. It's 1.96 into standard deviation on either side of the mean. So if you look at 1.96 into 3.5, that comes to about 6.8. That means there are a lot of patients who, or perhaps there are some patients who have much lower than 1 year follow-up. So that this whole range really goes from 0 to 9, 10 or 11 years or so, or say. So there are significant number of patients who have less than 1 year follow-up, or even definitely less than 2 years follow-up. Is a lot of patients which are there. So then, can you actually talk about progression when there is only 1 year follow-up after whatever procedure you're doing? Because we know glaucoma is a very slowly progressive disease. So this is a very large standard deviation here. Sort of casts a shadow on how we interpret this study. Again, the plateau iris configuration is not really a part of the spectrum of appositional angle closure. It may coexist, but then how you tie it up together is really a little bit of a conundrum here. But then is it really valid to actually separate the three, where you say pupillary block versus primary versus PIC versus extensive exaggerated lens vault? There's definitely going to be some overlap in these. So how they have teased that out is it's not really clear. Again, univariate and multivariate logistic regression is used here. So we use logistic regression when the outcome is a binary. It's a yes no. So here it's progression, isn't it? So did progression happen? Yes or no? So it is a binary. So here they have used logistic regression. However, the time to that progression is, I think, really critical in these kind of, in glaucoma studies, where you say, when did progression happen? After 3 years, after 4 years, or after 5 years, or, whatever that time may be. So when time becomes an issue for a binary outcome, the better way to look at it is using survival analysis. And, we have an output which is called Kaplan-Meier curves. So you might actually do a bit of reading. So there is a blog that I have written very recently on survival analysis, and that actually might help some of you. Okay. So I think Anujit has already brought this up, where, what stage was that pupillary block is not at all given anywhere. At least I couldn't find it when I read it quickly. So how many were actually PSCS and how many were more towards the PSCG spectrum is something that is not at all given. So it's difficult to interpret. So odds ratios, an odds ratio of 0.96 is 4% reduction in that likelihood of progression happening with every 1 micron increment in retinal nerve fiber layer thickness. That's how you interpret it. So if an odds ratio of 1 means there is no increase or decrease, odds ratio more than 1 is increased risk, or so this is not risk, this is likelihoods. So this odds ratio of 2.8 is if you are in the pupillary block group, your chances of or your likelihood of having progression is 2.8 times higher than if you were not in that, or than if you were compared to the PIC group, is what they've written here. Okay, now glaucoma progression, how many actually had progression is not given in the results overall. So we know now that there are 44 progressors, but in the results, they don't mention how many actually progressed and when, after how many months or years of surgery they progressed is again not given. A few other things. So, some sort of, statistical nuances. They say that IRB was waived because this is a retrospective study, nature of the study. So this is surprising because this is, 2022. So most IRBs actually now don't, they don't omit or they don't waive off. They will ask you to present, and At least in India, that is getting more and more strong. And lastly, so when you compare across three groups here, there is pupillary block versus PIC versus exaggerated lens void. When you compare across three groups, you use the analysis of variance or Prussell-Wallis test. And when you compare across two groups, say age or whatever it may be, between progressors and non-progressors, that is two groups, what we generally use is the PAIR-T test. So that is what this, it's nicely kind of understood from the way they've given up. Again, like I said, the average follow-up is not the right way of reporting outcomes in a retrospective study. Again, they say, last thing I wanted to show you is if you look at intraocular pressure at baseline, so this is baseline characteristics. This is 20.6, 20.5, and exaggerated lens group at 27. And that's really almost 7 millimeters of mercury more, definitely clinically significant. However, it is not statistically significant. And now this is because the sample sizes are very small. So that's why this P is actually not significant. So P is mainly influenced not by the mean, but by the sample size is sort of the take home message. And, because this is high, you see mean reduction is more in this group. This is the exaggerated group, 4.6 millimeters mercury. That's because the baseline is high. The other groups don't have much to reduce now because they're already sort of in the late teens or early 20s. So there is not much scope for them to reduce. So that is called as regression to mean, where we are already close to, that's again when happens when somebody has 6/9 vision, how much can he improve? Same way, when the IOP is already slightly low, at least for glaucoma considerations, it's not going to go even below that. So, so these are some of the things, I thought we would sort of discuss. And okay, one quick thing is, when you look at multivariable analysis, in a logistic regression, the number of factors that you can take, you can't take like 10 factors to look at that outcome. There are 44 events here, right? There are 44 progressions. So you can actually study only effect of 4 factors. And that is what they have done actually. So they have looked at the type of, the angle closure mechanism. Then they have looked at central corneal thickness, and they have looked at baseline average non-fiber layer thickness. So this is, relatively okay. But, like I said, overall, there are a lot of sort of, I think, deficiencies, and, it's slightly difficult to take this study at face value.
Thank you so much, sir, for giving your time to us today. This is, he teaches us how to look at the paper with a microscope, really. I'm pretty sure none of us would have realized these, subtle nuances here. Next, I would like to invite Dr. Anu June to share some positive aspects of the study with us. So she is assistant professor at Maulana Azad Medical College, Guru Nanak Eye Center. She's actively involved in teaching and research and has participated as a faculty in various state level and national level conferences. She's also the reviewer for strabismus and glaucoma section of Delhi Journal of Ophthalmology and assistant editor of the YO Times Pediatric issue and DOS Times Glaucoma issue. Over to you, Dr. Anu.
Thank you, Dr. Sonal. Is my screen visible?
Not yet.
Just a second. Yeah. Is it now?
It mentions that you started sharing, but not yet visible.
Yeah, now it's visible.
It's visible now.
All right. So after talking about a lot of limitations of the project by Dr. Anujita, as well as very relevant points highlighted by Dr. Sen Gupta sir. So let's just talk a few good points about the study rather than being absolutely critical. So what I really liked about the study was how they, wanting to go about a different mechanism that has affected the progression. They talk about how it's not being differentiated. The progression has not been differentiated by the various mechanisms. So they are looking into something novel. Whether the results are corroborating with it or not is a separate issue. Then another point that went in favor of the study was that the patients were already enrolled in the ASAN glaucoma progression study. It's very difficult to look back to a 10-year retrospective project and have, all the details. As Dr. Anujit was talking about, there's almost a 50% loss of subjects from the previous study. But then the other 50% could be recruited only because they were already a part of the previous study. So most of the details were really available. So they tapped into a good project and made it a second part of the study rather. 10-year follow-up for a study is a good enough period because most of our studies that we see being published have lesser period of follow-up or lesser duration of the study. So they recruited patients from March 2008 to June 2018. It may be small when we're talking about a disease which progresses very slowly, but compared to other studies, 10-year period recruitment is a good period. And surgery by a single surgeon again goes in favor of the study because, as we all know, surgery in a angle closure patient might be difficult. It may have complications with, a lot of iris prolapse or chafing and post-operative IOP spikes. So a single experienced surgeon operating these patients was a positive aspect in the favor of the study. They have included a lot of definitions and really tried to categorize what they mean by each group. So they've mentioned what patients were taken as PACS or PAC or PACG. They included the ISGO classification systems. They went ahead and talked about all the structural and functional parameters also. So all the inclusion criteria have been well defined. So talked about the reliable visual field test results, and at least 7 fields were available for all of these patients that were included in the data, which is a good enough field number. 2 fields were pre-operative, one at baseline and another one at 2 weeks. And more than 5 reliable fields were taken after the lens surgery. And most of these, as they've mentioned somewhere here, are 6 to 12 month intervals. So 5 fields post-surgery is also good, although how much it can, talk about progression, that's another concept. Exclusion criteria, Dr. Anujit has highlighted that they haven't mentioned a lot of exclusions, but whatever exclusions they've done, they're quite relevant, secondary glaucomas and patients who've had previous surgery or anything that could interfere with the outcome of this project. Dr. Sen Gupta was rightly pointing out as the mean follow-up of 6 years. They have, however, mentioned that a minimum of 2 years follow-up in the fields have to be there. Otherwise, those patients were excluded. So any follow-up of more than 2 years. We do have to take it with a pinch of salt here, as Sir was highlighting about the interval plus 3.5 range, which means some patients might have had a follow-up of less than 1 year, although the study points out that their follow-up examination of minimum 2 years was included. So minimum 2 years, and most of them going into 6 plus 3.5 would be a good enough period. When we talk about the scanning, they've mentioned the images of good quality were included. So all those images which had less than adequate quality or poor fixations were rejected for the study and not included. That is why there was such a loss of patients, almost 50% loss. Masking here has been mentioned, although it is a retrospective study. So maybe that was possible because these patients are already recruited for another study, and hence masking was a prior criteria. Again, to not have any intra-observer bias, they've taken 2 specialists who have independently classified all the data and all the mechanisms, and they're not aware of the diagnosis made by each other. And a third person was recruited only when there was a confusion in the diagnosis of these two. So that goes in favor of the study. They've also mentioned the guidelines for categorizing these 3 mechanisms. They've highlighted how they've categorized whether it's a pupillary block or a plateau iris or an exaggerated lens vault. Although again, they haven't mentioned very objective parameters. They've tried to just highlight it subjectively, and there could be variations in that. But taking into account 2 experienced specialists grading the same thing might go in the favor. When we're talking about progression, again, 2 experts have independently assessed these progressors, whether it be structural parameters like the fundus images or the RNFL images, or whether it be the functional parameters like fields. And these 2 graders were again unaware of each other's assessment. So that's a good thing. Progression is also taken into account both the event and the trend-based approaches. So they're trying to look at the data as a whole, despite the limitations. When we talk about the results, the average follow-up, they say is 6 plus minus 3.5. So those patients which actually were followed up for 9.5 years would be a good follow-up period. But again, the patients who were followed up for 6 minus 3.5 years would definitely be a hindrance and a limitation, like it has been rightly pointed out with Anuji. The last thing I would like to highlight here, I'm not going to talk about the results. So results is a separate thing altogether, discussing the methodology, how they've tried to go about the study. But then they have definitely a very big negative pointer that has been brought out by both the previous speakers, is that they haven't individually classified, PACS, PAC, and PACG in these 3 mechanisms. So of course, somebody who has a PACG would probably progress faster. And if a particular group has more of PACG than a PACS, that group might show more progression. So they have highlighted that in the limitations of this study, and they're owning up to that. So I think that was a good pointer. And I think overall, a lot of discussion and a lot of limitations in the study, but the way they went ahead with the study, trying to take whatever they had and make a study out of it, the methodology and all was good enough. Over to you, Dr. Sonal.
Thank you so much, Dr. Anu. Now, after these positive points have been highlighted by Dr. Anu, I would now request Dr. Sahiban. Actually, Dr. Prasanna is experiencing some technical glitches, so he's requested to go last. I'll now request Dr. Sahiban to, share some of the points with us. I'll introduce her as well. So, Dr. Sahiban is currently working at Arunodaya Desert Hospital at Gurugram. She's completed her long-term glaucoma fellowship from Shankar Nethralaya, and she's completed her post-graduation with a gold medal. She's also served as assistant professor at RIU Sitapura and at Savita Medical College, Chennai. She has presented in various national and international conferences, including ASCRS, and she's also won the International Heroes Award at AIUS 2020 and Developing Country Eye Researcher Award at Arvo, Florida 2014. So over to you, Dr. Sahiban.
Thank you so much, Dr. Sonal, for that introduction and for having me here. So good to go? Right, so my role over here today is to introduce what are the newer concepts in the management of angle closure glaucoma. So what I'm going to do is that we are going to cover the spectrum of what is new in the pathogenesis of angle closure, what is new when we look at evidence-based management of angle closure in our clinical practice, and what is also new when it comes to the future of angle closure. So now we've discussed in this journal what we know. These are the different mechanisms. We know about pupillary block, we know about anterior rotation of the ciliary body causing plateau iris, we know about the high lens vault. But what we forget very often is that there are about close to 50% of PACG patients who have multiple mechanisms leading to angle closure, and you cannot clearly in black and white categorize them into one category alone. So what we don't consider very often is maybe a presence of a ciliary choroid detachment, maybe a presence of a ciliary body cyst. Now, the limitation in most of these trials is the fact that they use ASOCT for categorizing the mechanism of angle closure, and all these mechanisms cannot be picked up by an ASOCT unless, of course, a UBM is being done. Now, what's new? The new thing, the new concept in the pathogenesis of angle closure is the dynamic behavior of the uvea. When I say that, I mean that significant changes in the iris volume have been observed, and they have been postulated to be a major pathogenic factor for primary angle closure glaucoma. Now, in simple words, what happens is that in narrow angle eyes, the iris volume is found to increase after pupillary dilatation, which obviously leads to crowding around the angle. But in open angle eyes, when you dilate the pupil, the iris volume significantly decreases, thereby causing no crowding around the angle. Now, this phenomenon could probably be explained by different fluid movements in and out of the iris stroma between angle closure glaucoma patients and normal patients. Another concept is the concept of choroidal expansion. It said that angle closure eyes have significantly thicker choroidal thickness than open angle eyes. Now, what this can do is a thick choroid can push the lens iris forward and cause crowding of the angle and cause a dynamic rise in the intraocular pressure. Now, what are the current evidence-based treatment approaches that we adopt? Well, it has been established that there is a very limited role of PI, and a PI only relieves pupillary block, so naturally doesn't apply to other mechanisms of angle closure. And 80% of these eyes, in spite of PI, have residual peripheral anterior synechiae, which makes this less and less popular with time. Now, Eagle's study was done in 2016 and was published in the Lancet, and it still holds as a landmark reference when it comes to treatment of angle closure eyes, which says that clear lens extraction is much more superior to PI as a primary treatment of angle closure disease, and also is a more cost-effective option. So when we're looking at phaco and angle closure eyes, what are we trying to achieve? We're either trying to prevent progression to PACG. Now, in that case, phaco only makes sense, or clear lens extraction only makes sense if the extraction is done early on in the disease process before the formation of PAS. But if you're using phaco in managing established PACG patients, it only makes sense if it's done in early to moderate cases of angle closure. And it has limited role as a standalone procedure in advanced cases wherein a trabeculectomy or some filtration surgery is mandated. Now, there's also a lot of hue and cry about phaco with goniosyncylisis. Now, there are multiple studies which has proven the efficacy, and the IOP reduces to about 20 to 30%. However, the dysfunction of aqueous humor drainage cannot be solved by this, so it is inefficient in advanced stages. Now, the rule of thumb is that if you have a medically controlled PACG with cataract, you can go ahead and do a phacoemulsification alone. When you have a medically uncontrolled PACG with cataract, you have to do a phaco with a trabeculectomy to control the IOP. A clear lens extraction is indicated only in mild to moderate PACG or in PAC eyes where IOP is more than 30 millimeters of mercury, especially for aged patients above 50. Now, when you have a medically uncontrolled PACG eye without cataract, go ahead and only do TRAB. There is no need for cataract extraction, especially in younger patients, so that you can retain their accommodative ability. Now, the newest kid in the block is MIGS, the minimally invasive glaucoma surgery in PACG, which has recently been added to our armamentarium. However, let me give you a word of caution. MIGS devices are not licensed to be used in PAC eyes yet. But is Schlemm's canal surgery effective in treating PACG? The answer is yes. The rationale being that very often we forget that the only treatment plan that we should have for an angle closure disease is not just opening up the angle. We also have to address the fact that the trabecular meshwork and the Schlemm's canal is also dysfunctional in these eyes. So how do you treat that? Again, a lot of studies being done wherein goniotomies have been combined with phacoemulsification and goniosyncylisis, which have shown very heartening results. There have been IOP reductions of as much as 33.5% versus just to 23% in cases where goniotomies were not done. There are other studies where IOP reduction of close to 50% has also been seen with goniotomy included. Now, there are also a few larger RCTs that are in the way, which have been which are being carried out by the Zhongshan Ophthalmic Center. And these are probably going to bring out more newer options for management of angle closure when it comes to the perspective of MIGS. There are also eye stents and hydrous implants, which are being used as off-label. And there is a certain study which did phacoemulsification with an eye stent implant, and the highest success rate in that study was achieved in angle closure eyes, even when compared to open angle eyes. Then there's another study which found, although that the placement of these implants can have occlusion of the eye stents by the iris, by the formation of PAS in about 27% of the eyes, but IOP was increased only about 2.7% of these patients. There have also been endoscopic cyclophotocoagulation studies, which again is a sort of an extension of a mixed procedure because it is ab internal. This is the first study which was published in IGO in 2019, and it's a good read, I feel. So that's my time. Thank you. I hope this helps. I cannot really cover everything in detail, but yes, I've introduced the concepts for further reading for everyone. Thank you.
Thank you so much, Dr. Saiban, for being so concise and brief, and yet covering such a vast span of this is such a hot and debated topic of what exactly has to be done in these particular cases, and covering the latest on this particular topic was a pretty daunting task. Next, I would like to invite Dr. Prasanna Venkatesh Ramesh from Mahatma Eye Hospital Private Limited at Trichy. He is also a gold medalist, and he has published 95 articles in various peer-reviewed journals, including 46 in the IGO, and he's been a much awarded surgeon, I should say, at WGC, IRSI, AIOS, GSI, TNOA, LV Prasad, DOS, and Arvind Eye Care conferences. His areas of research are glaucoma, moving images, augmented reality, artificial intelligence, 3D printing, app developing, and academic filmmaking. He will be sharing the shortcomings which he has, sort of really worked hard on. So over to you, Dr. Prasanna.
Thank you, President Ma'am, and the elite panel here for giving me this opportunity. Apologies for coming out of order due to a short technical glitch, and it was a very nice journal club, I should say, and there are many points that were covered, and I'm just going to summarize the negative aspects. And being a retrospective study, I felt, am I audible, ma'am?
Yes, you are audible. Please.
Fine. So the first point for me is being a retrospective in nature, that itself was quite taking aback, because the study felt too good to be true, because it was retrospective in nature. And when there is a retrospective nature, are we going to really mask something, is something that was running in my mind when this particular topic that came up, where 2-3 people, the same surgeon was actually the one who was also tackling the progression. If there was a bias between Dr. A and Dr. B, then the C came into picture and he was to be the surgeon. That was one thing that didn't really go well. And I'll keep my points. I have 7 points for the next 7 minutes, which I'll be summarizing. The second thing is, as Sengupta sir rightly pointed out, the standard deviation of 3.5 years was almost slightly, it is more than half, I should say, of the 6 follow-up years. So that was again another negative aspect that I would like to really point out, because there were many people who were having a lesser follow-up period of less than 1 year or 2 years, that could have caused a skewing towards a lesser follow-up period for a disease like glaucoma that seemed to be very, very low follow-up period. That is my second point. The third point I would like to emphasize is again one of the points that Sengupta sir pointed out. In the heading, it's told as it is glaucoma, but in the methodology, it is told about the spectrum of disease. It's told as if it's a primary angle closure disease spectrum. So are we seeing a spectrum, or are we seeing only the PACG? That is something that maybe we'll have to ponder our minds over it. And another point that again, it's more like a summary. 52 were there in the pupillary block group, 51 were there in the plateau iris group, and 15 were there in the effective lens, the exaggerated lens fault group. The samples seem to be slightly skewed. They were not equidistributed. And as rightly pointed out before by the speakers, that could have been one of the reasons why the exaggerated lens vault group had a huge reduction in IOP, because their baseline also seemed to be high. And when the effective lens, the lens was removed, then the IOP automatically reduced, as was pointed out before. So all these imbalance between the 3 groups could also cause another one. That was my third point. And adding to my fourth point, the effective lens, the exaggerated lens group, is it really ethical is another thing that we always discuss when it comes to our population, taking it in a pinch of salt. Still, there is a fine line of balance. Is it really going to be applicable in our population? That's a huge debate, maybe for another day, or maybe the speaker after me could summarize on that as well. So the ethical point of view should also be brought into the picture, whether early lens extraction, is it really possible in our country, is another one. Could it be really applicable for our population, is one. And then there is a clear-cut operational diagnosis that we all need to work on. We have 3 groups: the pupillary block group, the plateau iris group, and also the third group is the exaggerated lens vaulting group. what is the diagnosis that the author wants to give us is something that is in my gray area. I'm not able to find out, is this a particular pinch region that we used to call where the iris, posterior iris in contact with the anterior lens surface, what was the length of it, what was the height of it? Usually in a pupillary block, the length of it will be more and the height will be lesser for the opposition to actually take place between the posterior iris and the anterior lens. That is something they could have really defined, which I felt the paper did not define. And third thing, when they bring in a surgeon, I always feel more about the surgeon's experience of the surgery. What is his complication rate or something more, rather than telling about a single surgeon and telling about the KRS as an initial. Rather than that, what could be slightly more for a surgeon? And even a single surgeon is one of the limitations that I could say, because maybe a multi-surgical approach with a multi-centric approach could have really made more difference according to me. And these are some simple points, but I felt it's more effective. And the penultimate point is randomization. One eye was randomly selected was what the author cited. I would always recommend, how did you select that one eye? Was it a simple randomization? Was it a flip of a coin? Or did you select the left eye for all the patients or the right eye for all the patients? These are some lines that the author uses. Left eye was performed at the surgeon's discretion. The lens extraction. Can the surgeon get too much power in selecting the eye that he wants to perform a lens extraction? Because the same surgeon is the one, when there is not a consensus arrived between investigator A and B, he comes in to actually say what is right or how can the classification be made for glaucoma progression. So there seems to be too much of bias in the name KRS, because though it seems to be masked and everything, being a retrospective nature, I do have my reservations while taking this study, because you can see, I quote this line: two experienced glaucoma specialists, MKS and JWS, independently classified the AC mechanism using ASOCT. But when they could not reach a consensus, a third glaucoma specialist, KRS, made the final decision. So KRS made a final decision when there was no consensus. He was the only surgeon who operated. And there is another line which says lens extraction was performed by the surgeon who had discretion. So these are some things that I wanted to bring into, and these are some of the negative aspects that I want to highlight. And thank you for this opportunity to the president and the elite panel for giving me this opportunity. Thank you once again. Yeah.
Thank you so much, Dr. Prasanna, for joining in and sharing all these valid, very, very valid points. And I just secretly hope that the surgeon KRS was not listening on the YouTube live, as he's, really being
I also hope
by
so.
each and every friend.
I also hope so that none of the authors also did not listen to some things, but these are some simple observations. Maybe I may be wrong.
So that is how actually we learn how to read papers with a with a very panoramic view, rather than just taking everything that is written and believing it. So next, I would like to request the mentor, Dr. Rajat Mohan Srivastav, who's associate professor at the prestigious KGMU Lucknow. He's also the co-in-charge of the glaucoma subspecialty there. He's done his MD from RP Center AIMS and is a well-known and avid researcher in the field of glaucoma as well as anterior segment. So he has helped Anujit summarize these results so beautifully, and he will now summarize the entire paper and what all we should learn from it, after having listened to the panel of experts and our research expert, Dr. Sen Gupta. So over to you, Dr. Rajat.
Thank you, Dr. Sonal. First of all, I would like to congratulate Anujit for such a wonderful presentation. It's taken up all the points well. And I would also like to thank all the panelists and Dr. Sen Gupta sir for highlighting those important points while discussing this paper. Now you see, this is an interesting, if we talk about this paper, it's a very interesting take by the researchers who have actually tried to explore the relationship between the anatomic basis of glaucoma and to study how it is related with the progression, especially in the angle closure disease. So previous studies have known to show that there is significant amount of reduction in the intraocular pressure if you perform lens extraction surgery, especially in angle closure disease and even in other forms of glaucoma. So what the authors have uniquely tried to assess is what is the anatomic basis for progression in the eyes who have undergone a lens extraction in angle closure disease? So that's a unique question to answer actually. So they have made commendable job to find out results. Now here, one thing I would like to highlight to all of you, that in the process of defining all these criteria, what they have primarily uh, um, relied upon is the ASOCT parameters done prior to the lens extraction for classifying these patients into three glaucoma groups as a pupillary block glaucoma mechanism, a peripheral iris, a plateau iris configuration, and an exaggerated lens vault. So now they have tried to understand how many of these patients will progress and what are the reasons for progression in these disease. As correctly pointed, the progression of the disease and the surgery have been done by common people. So there is bias in spite of the fact that a lot of effort has been taken into consideration for masking. And they have tried to define all the definitions properly, but still, because of the retrospective nature of the disease of the study and because of involvement of the surgeon in diagnosing progression, makes it a little biased study. Now, if we come down to results, now if I'll just try to summarize the important results which we get from this study is that if we compare these three mechanisms, the pupillary block, the PIC, and the elevated lens scrub, what we see is that the preoperative visual field RNFL and analysis, if we do for all these groups, they're all similar. So it means that no matter which group we are considering, all of them have similar baseline glaucoma characteristics to begin with. And what happens post lens extraction is there is a significant amount of reduction, and the reduction is more in elevated lens vaulting. The point has already been highlighted by Dr. Sen Gupta that the pressure was actually higher in the elevated lens group, and that is why we find a significant reduction compared to others in the elevated lens group. But by and large, what we understand from this study is no matter what kind of angle closure disease we are dealing with, lens extraction was definitely going to cause reduction in the intraocular pressure. Another important thing which we should understand is that the baseline characteristic for intraocular pressure, preoperative IOP, and even the IOP fluctuation for all these group were same. And even after surgery, the final mean operative intraoperative pressure and the mean intraoperative reduction and the fluctuation were common in all the three groups. So what we realize here is that all the three groups for primary angle closure disease, they have been similar in terms of characteristic to begin with, and they also end up being on the same side when it comes to analyzing the mean intraocular pressure post-surgery, the fluctuations. So there isn't anything significant different in these three groups to ascertain which of them is going to progress. So that part of a question remain unanswered when we consider all these three groups together. A point which I would like to highlight, which probably got missed during the study, was that the history of repeated attacks and the number of patients who had undergone peripheral iridectomy were also similar in all three groups. So these are certain criteria, these are certain things which could have indicated, the disease severity in a particular group. But because all of them have a uniform distribution in all three groups, there weren't any typical risk factors for progression to be seen in these groups. Now, when we go into further analysis to assess the factors which are responsible for progression, what we end up seeing is that the pupillary block group, they are twice more likely to have progression compared to the peripheral iris configuration. Now, that is just one statistical correlation which we get, but we don't get any specific reasons for why such a thing would have happened. One of the analysis which we get when we are comparing the progressors versus non-progressors is that the preoperative visual field index, the visual field score, mean deviation, and the RNFL, all three of them were lower in the ones which got progressed. So that these are the risk factors for progression. But how they are distributed, these risk factors are distributed in the three anatomic groups, which were the primary reasons why we conducted the study, have not been defined in this study. They have talked that the lower CCT is also another factor which is actually responsible for causing progression, which is also responsible for causing progression in this disease. But what they have not compared is what was the mean follow-up period for progressor versus non-progressors, because that's an important bearing to have to understand why particular disease progressed and why the other one didn't progress. Another thing which I would have probably, if I would have studied, I would have liked to understand was that what was there any difference in the number of attacks the progressor had compared to the ones who did not progress had, and the number of medications in the progression group compared to the non-progression group. The only thing they say is that in the progression group, the number of medications were high, but how were they distributed in the other group before doing a progression analysis is not mentioned here. So to summarize, what we see is that if we have these three mechanisms, the most likelihood for getting progressed is the pupillary block group. In fact, the plateau area group forms as almost like a protective factor when it comes to progression. But in the absence of knowing what was the average follow-up period for progression versus non-progression, this doesn't really make much of a difference. And secondly, if there were progression, what were the other factors which could have resulted in this progression? Because the mean IOP fluctuation post-surgery in all these three groups were same. So that's one of the risk factors which get ruled out. So the only other factor which remains there to explain such a progression is about the systemic control of the of condition in these patients. And since that part of the thing is excluded from the analysis in this study, it is very difficult to ascertain what were the reasons of progression. All that we can really understand from the study is that if you have got a pupillary block, there are higher chances of progression, but we cannot truly ascertain the causes for such progression in these groups. Now, one more thing I would like to say is that while performing this analysis, it would have been better if we would have also known about other risk factors such as family history in these patients, because that's another risk factor which can be ascertained to glaucoma progression. But unfortunately, these things have not been mentioned. So if you have to conclude all this study in one simple sentence, it would simply mean that no matter what kind of angle closure disease which we are dealing with, if we perform a lens extraction, an uneventful lens extraction, there is going to be reduction in the intraocular pressure. But will that intraocular progression, reduction in the intraocular pressure be protective in terms of glaucoma progression? This still needs to be studied in in another study, maybe a prospective study, wherein we can truly understand what are the actual risk factors in these anatomic groups, which can explain why some of them progress and whereas others don't progress, especially when the mean intraocular pressures, the intraocular pressure fluctuation remains same in all of them. So these are all things which I would like to summarize at the end of it. And everybody else has already highlighted most of the points together. And I hope these things really help the audience in understanding the gist of the paper. Thank you.
So thank you, Dr. Rajat, for wonderfully summarizing the whole crux of this JC presentation and the article. So Dr. Sengupta has just typed in a comment that time inclusion was essential. Therefore, use survival analysis in glaucoma and not logistic regression. So one of the statistical nuggets. So, before we wrap up with the vote of thanks, anybody in the audience would want to, any audience questions, anybody would want to ask? We have our expert panelist here, or if any of the panelists would want to.
I actually do have a comment.
Yeah.
Just in the defense of the author, the same author did publish an article which dealt with glaucoma progression in different disease spectrum of the PACD group. So they did look at PACS, PAC, and PACD PACG separately, and they concluded that PACS and PAC patients did not progress after lens extraction. The only progressors were the PACG patients. So, the conclusion was that lens extraction alone is not sufficient for a PACG patient. You need to go ahead and probably medically manage or surgically manage them even later on. So this was published in Journal of Glaucoma only in 2020. So yes, I think very smartly they have segregated their single, research into many papers. And that's why looking at the disease in totality is very important, rather than just looking at a primary angle closure disease as a phenomenon where you just, deepen the anterior chamber and just let it go.
Yeah, very rightly said. One more point I would just like to say, Anujit in his study, in his slides has mentioned that the study was sponsored. Now, when we look at this study, which appears to be a retrospective offshoot of thought, when they have conducted a previous study, because they mentioned that the recruits were from a previous study. So it also gives an impression that once they had completed the study and they got funded again, so they might have just, relooked at the data because of the pressure to come up with something which can be beneficial. But in doing so, they ended up in doing a lot of mistakes. So we really can't take up the paper in its face value. And we have to understand that lens extraction is not the solution for angle closure disease. You have to do trabeculectomies or do active management even after doing lens extraction for preventing progression in disease. Maybe that could be a reason that they were funded, so they just had to do one more reanalysis of the data they already had, probably to get to some results. Not sure though.
So, yeah. So, do we have any more comments from the audience or any more questions to be asked? Okay. So, so I think if we don't have any further comments, so I would just like to, 1 second, I will just share my screen, and I would like to present. So my screen is visible, right? Yeah. So, we from the Journal Club team would like to present the certificate of presentation to Dr. Anujit Paul for a wonderful presentation of the article, very, very well presented. And we would like to also present a certificate of appreciation to Dr. Sen Gupta, who's been the crux of the Journal Club. He's very busy, but he always spares time to fine analyze the article, give his statistical nuggets, help us analyze the article. Then again, certificate of appreciation to Dr. Rajat Mohan for being the wonderful monthly mentor for this Journal Club. Thank you. Your summarization of the your help to Anujit is really appreciated. Then we would like to also appreciate our panelist, Dr. Anu June, for wonderfully highlighting the positive aspects of the article. Then Dr. Sahiban for wonderfully, very concisely and precisely bringing out the newer advances in the field. And Dr. Prasanna for bringing out the negative aspects of the article. So thank you all, and for a very wonderful Journal Club session. So our next Journal Club session will be in September. Topic would be on pediatric ophthalmology. Dr. Gunjan Saluja, one of our YOSI executives, which has taken the lead to sort of monthly mentor this topic, and we'll be coming up with details soon. So look out for this space, and we will just call this a wrap. Again, sharing the official email ID wherein you can send in your interest. If you want to present any article, you have any feedback regarding these sessions, you're more than welcome to do so. And so that's it from us. And yeah.
Thank you so much. Congratulations, Anujit.
Yeah. So we'll be mailing all these certificates to you shortly. And I think Dr. Nilesh is also here, our joint secretary. Nilesh, would you want to? Hi.
Hi, ma'am. Hi. Actually, I was traveling. I was in flight. I just got down and I just thought I'll join in.
Yeah.
But I am sure Anujit must have presented very nicely. So I'll just see on YouTube, and I would like to thank our mentor Sunny sir for his guidance, ever support, and all the panelists, Rajat sir, Shaiban ma'am, everybody. Thank you everyone for making this awesome.
So before we call it a complete wrap, I'll just request all the panelists and Anujit to just stay behind for a group pic. And we can also stop the live streaming on YoTube. So Anujit, can you do that?